Welcome to the Neurology Video Journal Club. I'm Dr. Kathleen Digre. I'm a distinguished professor of neurology and a professor of ophthalmology at the University of Utah, and I've been the division director of headache and neuro-ophthalmology. And I have my great colleague with me here today that I'll let her introduce herself.
Thank you, Dr. Digre. I am Dr. Pham, and I am an assistant clinical professor at the University of Utah in the Department of Neurology, specifically focusing on headache.
So today we're going to be talking about a really interesting article, The Efficacy of Ubrogepant and the Acute Treatment of Migraine with Mild Pain versus Moderate or Severe Pain. And this is an article that came out in Neurology in late 2022, and it was written by Dr. Richard Lipton and his colleagues. And Dr. Pham and I are going to be discussing this article. Migraine affects about 10% of our population, and it's the second most common disabling condition. So we should really care about this. Migraine is a major health problem, and healthcare providers need to be able to make the correct diagnosis of migraine so that patients can get treatment and receive medications that can eradicate their pain and get rid of their most bothersome symptom and get back to functioning again. We're fortunately living in a time where we now have more therapies for migraine than ever before, which is totally great. But we are learning more about how and when to treat our patients effectively, because migraine can be mild, it can be moderate, it can be severe, and we know that those severe attacks are extremely disabling to our patients, and our job is to get our patients back to work and not be disabled. This is an important study. Now, in the past, we've learned from our patients that they have three desires. One, they want pain relief to be complete and quick. The second is they want their most bothersome symptom to be gone. And the third is they want any medication they take to have no side effects. So Ubrogepant is an oral calcitonin gene-related peptide receptor antagonist, and it's been approved for the acute treatment of migraine in 2 phase 3 trials that have been published before. Now, this study will be a discussion of the article by Lipton and colleagues and will add information about when to take Ubrogepant. So I'm going to ask Dr. Kendra Pham to tell us about the study by Lipton and his colleagues.
Well, thank you, Kathleen, for giving us that wonderful introduction. This study was a phase 3 multi-center randomized open label dose-blinded 52-week extension double-blinded study to evaluate the safety and tolerability of Ubrogepant in treating acute migraine. The study added on to participants who had been enrolled in the Achieve 1 or 2 trials, and their hypothesis was that treatment of migraine with Ubrogepant while pain was mild would increase a chance of a positive outcome in the study pain freedom versus when treating pain when it was moderate or severe. Adults were randomized into usual care, Ubrogepant 50 milligram or Ubrogepant 100 milligram groups, and each participant could treat up to 8 migraine attacks of any pain intensity per month over a 1-year time period. The authors only collected the outcomes for the 2 doses of Ubrogepant, including pain freedom at 2 hours, freedom from associated bothersome symptoms and disability. And the authors analyzed when these participants took the Ubrogepant, whether it was while it was mild, moderate, or severe. And then they also looked at the other metrics at 2 hours, 24 hours, and 48 hours. The participants could take a second dose if necessary, with a maximum dose of 200 milligrams per day. And the participants did know if they were in the usual care group or the Ubrogepant group, but they did not know what dose of Ubrogepant they were receiving if they were in one of the Ubrogepant groups. The participants could take any rescue medications, including analgesics, antiemetics, or triptans. And the researchers really only collected the participants' response to the Ubrogepant treatment, not the usual care treatment group. Data they used, they collected via e-diary, and they used alarms that were programmed to ring at each of the different time points to remind the patients to enter their data. And the participants recorded several things. They recorded pain, which they recorded as either no pain, mild pain, moderate pain, or severe pain at 2, 24, and 48 hours. They recorded their bothersome symptoms, so photophobia, phonophobia, or nausea and vomiting, pre-dose at 2 hours, 24 hours, and 48 hours. They recorded their functional disability on a scale from 0 to 3, 0 being no disability and 3 being severely disabled. And the study concentrated primarily on that 2-hour endpoint. They also kept track of adverse events throughout the trial. So on this slide, you can see the following diagram shows the study population and how the patients were allocated. So the authors assessed 1,310 patients from the Achieve 1 and 2 trials, as seen here, and 1,254 patients were randomized, which you can see right here. They ended in total with 1,230 participants, 808 of which were in the Ubrogepant group. And you can see that here in this red box, the breakdown. They had 401 in the 50 milligram Ubrogepant group and 407 participants in the 100 milligram Ubrogepant group. And then over here, you can see that the usual care patients, there was 417. These patients, from those 808 that were included in the Ubrogepant groups, reported, or at least 19,291 were included in the study attacks. In addition to those 19,000 attacks, there actually were 3,400 additional migraine attacks that were excluded because they lacked data at the 2-hour time point. But of the 19,000 attacks that were included, about 3,900 of those occurred while the pain was mild, 11,000 of them were while the pain was moderate, and 4,000 were while the pain was severe. 86% of the study population treated attacks of greater than 1 pain intensity. And then just over 60% treated an attack while it was mild, whereas 99% had treated attacks while the pain was either moderate or severe. And this was the case for both doses of Ubrogepant. Thinking about the findings, the 2 Ubrogepant populations were evenly matched by age, sex, race, BMI, and 25% of the participants in both groups were on migraine preventive medications. The authors found that when the pain was mild, the medication treated the pain more effectively than when pain was moderate or severe. So if we go on to this next slide here, which shows pain freedom, at 2 hours in the overall group, there were higher rates of pain freedom when pain was treated while it was mild compared to when it was moderate or severe. The percentage of treated attacks that resulted in pain freedom is shown for both doses of Ubrogepant. Light blue indicates mild pain. The darker blue bars on the graph represent moderate or severe pain. You can see for the overall population that was on the left of that left-sided graph, and then the kind of right side of the graph looked at a subgroup analysis population. This included participants who treated both a mild and a moderate or severe attack during the study period. And so that's also shown, and they also showed higher rates of pain freedom when the attacks were treated while the pain was mild. Then, as you can see on kind of the right half of this graph, there are the 24 and 48-hour time points. The upper right represents at 24 hours, and the bottom right represents at the 48-hour time period. And as you can see in this next slide that discusses bothersome symptoms, this also held true with migraine-associated symptoms of photophobia, phonophobia, and nausea. The graph shows, once again, the percentage of treated attacks that achieved absence of the mentioned bothersome symptom for both doses of Ubrogepant. Again, light blue is for mild pain, and dark blue is for the moderate or severe pain. And the results are seen in the upper left for photophobia, the upper right for phonophobia, and nausea in the bottom graph. And then if we go on to this next slide, This looks at normal function. So you can see here the percentage of treated attacks that resulted in normal function at 2 hours is shown also for both doses of Ubrogepant. Once again, light blue is for mild pain, dark blue is for the moderate or severe pain. And as you can see, twice as many individuals had more normal function when treated while pain was mild than in the moderate to severe pain. This also is true for the same subgroup that I mentioned before, in participants who had treated both mild and moderate or severe attacks during the study period, and that's shown on the right. There were very few people taking a second dose within 24 to 48 hours in the mild group, about 20 to 30% versus about 40% in the moderate to severe group in both 50 and 100 milligram doses of Ubrogepant. Similarly, rescue medications were taken infrequently in both groups. Interestingly, this was true both in mild and the moderate and severe groups at about the same rate. And these data were not statistically significant. But what we saw was both 50 milligrams and 100 milligrams of Ubrogepant were successful, with slightly more success with the 100 milligram Ubrogepant in treating both mild and moderate or severe headaches for the acute treatment of migraine attacks. So, Dr. Digre, what does this study tell us?
Well, Kendra, I think this study really confirms how important it is to treat when the pain is mild. You know, we learned a lot about treatment of acute migraine attacks when we studied the triptans almost 20 years ago. And we found out with the triptans, if you treated when the pain was mild, you had a much better response than you had when the pain was moderate or severe. Now, the Ubrogepant study also shows that we get a better success when we treat when the pain is mild. And this is what the patient wants. They want fast, complete relief with a lack of bothersome symptoms, and they want to get back to their normal function. And I think that that's the message here, is that we're going to have to teach our patients to treat as often as they can when the pain is mild.
And Kathleen, why do you think it works better when the pain is mild?
Well, that's a really good question, Kendra. You know, the authors thought that maybe if the pain is mild, it means that it hasn't really established hold in the patient. In other words, it has a more peripheral onset where Ubrogepant could be active. And whereas when it's moderate to severe, this is when we get central sensitization, we get activation of the trigeminal cervical complex. That's when our patients say, oh, my hair even hurts sometimes when I get my migraine, and when it's moderate and severe, and mainly when it's severe. So when it's severe, the trigeminal complex is activated, and Ubrogepant does not cross the blood-brain barrier. So this may be one reason why it works more when it's mild. We do know that once that sensitization takes hold, it's kind of like it's going to take a lot more to get rid of a migraine attack. So, I mean, I always try to tell my patients, and I know you do too, treat when your pain is mild before the horse has left the barn.
That's a really interesting idea, and it makes a lot of sense. Why do you think patients actually have a hard time treating while the pain is mild?
Well, I think that there's several problems treating when the pain is mild. For one, people are afraid that their medication will lead to medication overuse. And we know that triptans, analgesics, etc., if you take too many of them, you can get into medication overuse. And so we don't think the Gepants have this problem. In fact, some studies have shown that maybe the Gepants are good at treating medication overuse. And for sure, we know that many Gepants have been studied now for the prevention of migraine. So I think that that's one reason. Another reason is the side effect profile of this drug is really low, and it's excellent. So, you know, patients should treat when it's mild, but they may be reluctant because they don't want to waste their precious medication on a little mild headache. They want to just say, oh, if this is really going to get worse, then I'll treat it then. And then they may have a limited supply. You know, many insurance companies limit the number of tablets somebody can get. And then the cost is another issue. Sometimes medications cost a lot of money, and Ubrogepant is a new medication. It's somewhat expensive. But you know, Kendra, what I look back on the triptan experience, there were economic studies done with the triptans that showed if you can get rid of that attack and take the appropriate medication, the expense actually goes down, and that there's an economic advantage to getting rid of the attack. As far as I know, there's been no economic analysis yet on Gepants or Ubrogepant in particular. So the other problem, I think, is that patients don't know exactly the time to treat, because you know, in migraine, 20% of patients with migraine with aura, about 11% of patients with migraine without aura will have almost instantaneous headache. In other words, the headache comes on and it's like there already. And researchers have found that you really have a hard time getting patients to treat when it's mild, because you have less than 1 hour to get that tablet in. And then we have some patients who wake up in the middle of the night and their headache is already at their maximum amount, and then they take their medication and it's just not as effective. They can't get it going right at the time. Now, Kendra, tell us a little bit about the safety profile of Ubrogepant. Do you think this is safe for our patients? And what did this study really find on side effects that could limit the use of it? Because we're excited about this potential great treatment that could give us pain freedom, get rid of our most bothersome symptom, and get back to functioning when the treatment is mild. But what did we find out about safety and tolerability?
Yeah, that's an excellent question. You know, overall, it seems like this is a really quite safe drug with very few side effects. The authors did report emergent adverse events for both the 50 and 100 milligram doses of Ubrogepant. They had slightly more in the 100 milligram dose. And the number one actually reported effect was upper respiratory infection at about 11%, followed by nasopharyngitis and sinus disease. There were very few serious side effects, only one treatment-related adverse event, which was reported as an arrhythmia, and only about 2% discontinued treatment because of adverse events. There were also no deaths reported in the study related to the use of Ubrogepant. So again, this looks like quite a good medication in terms of the safety and tolerability profile. And remember, the study was over an entire year. And so this is really quite good for how much that this was being used. And Kathleen, what are the strengths of this study?
Well, I mean, the obvious strength that this is like an amazing number of attacks, like 20,000 attacks over 1 year. I mean, that all by itself is a feat. So it's and it's real world data. That's the other thing I really like about this is these patients kept track of their migraine over an entire year. And the authors, you know, looked at each attack if they could get that 2 hour, but it was really a pretty good, solid group of patients and attacks. And just keeping this many people in a study over 1 year is, I think, also a real strength of the study. And I also think it was really patient focused, because it really focused on those three things patients want: pain freedom, quick, no side effects, back to functioning. And then I think the other thing that I really liked about the study is that they reported the most bothersome symptoms to the patient and showed us how treating when it was mild could affect those symptoms as well. And also they got people back to function. I mean, that's the problem with migraine is, remember, it's disabling in so many people. And I think that is a really important positive outcome.
Yeah, I couldn't agree with you more on all of those comments. As we know, there are weaknesses to every study as well. And in this study, what did you see as the weaknesses?
Well, one thing that I wish they had done was to tell us the outcome of the usual treatment. They had those patients, but they didn't keep track of what happened with their usual treatment. And of course, there was no placebo control in this study. So it would have been nice to see what happened in the comparison with those. The second thing I think is, only the patients that were in the Achieve 1 or Achieve 2 trial were patients. So these were already patients who had experience taking Ubrogepant, which I think was good, but also it can lead to biases as well. And then the analysis is looking backwards over the whole year. So it's kind of a post hoc analysis. But I think the authors really tried to standardize their statistical methods to get the best data interpretation possible. This was an open label study, so everybody knew that they were on Ubrogepant, but they had no idea what dose they were on. The providers also did not know. So in a way that was a strength, but in a way it could have been seen as a weakness. Now, the attacks were not randomized. So it wasn't like they randomized a mild attack versus moderate to severe. It was what the patient reported. And of course, that could be an individualized type of thing for somebody to report. The other thing is they didn't report the length of the attack. So some of these attacks could have been mild for a long period of time before they were treated, or they could have gone on for a much longer period of time. So we don't have that information. We also don't know if they had allodynia as a kind of a marker of central sensitization. We have no idea about that. And then the pain freedom is pain freedom, but we don't know what the response was, if there had been an analog scale, like I went from an 8 to a 2. Well, it may not have been pain freedom, but it might have been pain relief. So in other words, there were some things that would be nice to have known. And the final point I want to make, Kendra, is, when you have this many attacks, you're going to have statistical significance no matter what, because there's 20,000 attacks, okay? And in lots of studies, when you have huge numbers, you have this great statistical power. But then you have to ask, is this going to be clinically relevant? Do you know what I mean? On a real world basis. So these are some of the weaknesses that I see. What do you think it adds to our knowledge?
Well, I think the biggest take-home message that this study really tells us is that if we can treat the migraine attack while it is mild, this is ultimately going to be the best strategy for our patients. We also saw that, Ubrogepant has a remarkable tolerability side effect profile, and it makes it easy to use for patients. We also know that these drugs are not perfect. We did see that even when treating an attack while it was mild, over half did not have pain freedom at 2 hours, but certainly they're a good option for our patients, something else that we can keep in our toolbox to help our patients. But again, ultimately treating earlier in the attack is probably our best recommendation that we can give at this point in time with regards to how to use this medication. And Kathleen, what is your take on this?
Well, there are so many things we don't know about Ubrogepant, but also about Gepants. For example, do we know whether we can take a Gepant and a triptan in combination to get even faster relief? We just don't know that information. And, we don't really have complete long-term data on safety and efficacy about using it with maybe other CGRP monoclonal antibodies, or, for example, with other CGRP antagonists, as a preventative. Can you take an acute Ubrogepant with already somebody who's on a Gepant as a preventative? So there's some information here that we don't know. We also don't know if the Gepants, and in particular Ubrogepant or any of the other Gepants, can cause medication overuse headache. I mean, we think it doesn't. At least that's what we know right now. But I'm looking forward to more data to show that it doesn't. I love that this side effect profile is low, because I know my patients, they don't want side effects, and so many things can give people a side effect. And we have lots of patients who have cardiovascular disease that are really not candidates at all for triptans. And could this class of medication be really a good option? We think it might be able to, but I really would like to have more long-term experience with that patient population. I really think, Kendra, that ubrogepant's a great addition to our armamentarium for medication against migraine attacks. And this study really confirms that ubrogepant works best when it's taken with a mild attack. I'd like to have more studies on safety. I've already said that. I think this economic advantage of treating early with mild attacks, I think that's a perfect chance for people to study to see whether this is really a cost-effective thing for us to do. And I'm very excited to have it in my armamentarium. I think that, you know, we as providers need as many options as we can for our patients.
Well, Kathleen, I really appreciate all of your wise comments, and this was really an excellent discussion and hopefully a great episode as well. We'd like to just thank the viewers as well for watching, and we hope you all have a great day.
And I want to thank everybody for attending too. It's been a real pleasure for Kendra and I to come to you today. Thanks so much.